So this is a 60-year-old woman. She has a new onset severe headache. And when she went to the emergency department, she had a head CT that was reported as unremarkable. Can you tell me a little bit about the image at which we're looking?
It looks like CT angio, and the arrow is pointed near the MCA territory, so I'd say it's hard for me to tell when I'm not scrolling myself,
Right,
but
exactly.
but so I'd say like M1 territory possibly,
Yeah.
and there might be an occlusion or a cutoff there.
Well, like you say, the trick is that you're not. I don't have it set up so we can scroll up and down. So
Right.
let's say that the generously placed radiology arrow is pointing to a 5 millimeter left carotid terminus aneurysm. And so if we scrolled up and down, then we'd probably see the MCA fill out. Unfortunately, it's just too tortuous to show up on the axial here. So anyway, 5 millimeter carotid terminus aneurysm. How do you determine what specialist to consult? And I'll say, maybe more specifically, which specialist is going to manage the cause of this patient's chief complaint?
I feel like in terms of like vasculature, getting a diagnostic angiogram after CTA imaging is probably going to tell you more information in terms of whether something can be intervened on just from a neurointerventional standpoint, as opposed to calling a neurosurgeon to say, hey, let's open this person up. So that would kind of be my thought process behind that.
Yes, I think cerebral angiography definitely gives a more detailed anatomy. So a lot of times we have a pretty good sense of whether we might be able to treat an aneurysm or not with with the CTA, but the angiography does give us better information both for surgical planning and to see if we can coil something. But our next question is, does the aneurysm need to be treated?
I guess that would depend on symptoms or how the patient presented, if it was just headache or if they have like any other neurologic deficits. And then blood pressure control. I would say medical management first, and then consideration just depending on clinical presentation next when it comes to intervening.
So the natural history risk for rupture in the setting of a ruptured aneurysm versus an unruptured aneurysm can be wildly different, and certainly influences how we might approach this patient. So the head CT probably didn't show subarachnoid hemorrhage, and that's why they said it was unremarkable. What test could you do to try to sort out whether or not this aneurysm has ruptured?
And LP maybe?
CAT scan.
Well, the CT scan was negative, so LP for sure. Tell me a little bit more about that. Like, let's say you were doing the lumbar puncture. Maybe you're teaching a resident or student or something like that, and so you're walking them through it. What specifically about the spinal fluid are you going to be looking for to help guide you in terms of whether or not there's a hemorrhage?
See if there's endochronia or not.
Mm-hmm.
Yeah. So, that can show up in as early as 6 hours. It can take up to 24 hours. What else can help?
I'm not sure. I want to say opening pressure, but I don't know that that's correct.
If you have an elevated opening pressure, it certainly can guide you to, you can get hydrocephalus with subarachnoid hemorrhage, but of course a pseudotumor cerebri patient could also be presenting with a headache. So, that is important to measure. What about cell counts?
You mean just like RBCs?
Yeah. If you go ahead. I'm sorry. Okay.
Seeing the RBC count that's in the first and the third
or the fourth?
Right. So if we look at the red cell count in the first tube versus the fourth tube, it can help sort out the difference between a traumatic tap and a subarachnoid hemorrhage. So in general, and it's really helpful to do the very first and the very last tube to sort that out. But if there's more than a 50% drop, it suggests that probably was a traumatic tap. But those are things to guide you. So the reason I am mentioning this is really about that natural history. So for a ruptured aneurysm, the risk of repeat rupture with major stroke or death in the next 6 months is about 50-50. So as you said, we really want to be thinking about treating that aneurysm right away, more or less, either with coiling or with surgery. But for an unruptured aneurysm, it's a completely different animal. So, if this aneurysm is indeed at the carotid bifurcation, then we would call this an anterior circulation aneurysm. And the two things that affect the risk of rupture for, I guess, two biggest things for unruptured aneurysms is size and location. So, a size of less than 7 millimeters in an anterior circulation aneurysm has a very low risk of rupture. So it's not quite zero, but it's almost zero. So for this 60-year-old woman, if we say the risk of some kind of complication with treatment is about 10%, then really, unless we're worried, really worried about the history, there's something really pushing us to think she did have a hemorrhage, then it's more likely that a neurologist is going to be dealing with the patient's chief complaint of headache, because it's not very it's most likely in that circumstance that the aneurysm is asymptomatic. Vice versa, if your spinal tap is showing xanthochromia and there are red cells that are pretty similar between the first and last tube, then you're worried that the aneurysm has ruptured, and now it's definitely worth the risk to treat it. So there are several different studies that give some idea of the rupture risk, and it's more or less the same idea. The bigger the aneurysm, the larger the risk of rupture. And posterior circulation aneurysms, including, interestingly, the posterior communicating artery arising from the internal carotid, saccular aneurysms there tend to behave more like posterior circulation aneurysms in terms of the rupture risk. So, you go from 0% per year to close to that for a 5 millimeter carotid terminus aneurysm, but up to a 2.5%. Now that's over 5 years, so that's basically 0.5% per year. So even if it was a 5 millimeter basilar tip aneurysm, you still might leave it alone in this scenario. And then the anterior circulation, if you get over 7 millimeters, is about 0.5% per year. But you can see how things keep escalating. So that's really how how we decide whether or not we're going to treat an aneurysm or recommend watching it. And of course, there's some patients who might have anxiety. Having an untreated aneurysm may want to take a much higher risk of treatment than the natural history risk. But in general, that's more or less a rough guide in terms of how to deal with these unruptured aneurysms.